but it's work, so.
Good afternoon, everybody, and welcome to this afternoon's deep dive. I think we are ready to get going, and I see Dr. Neil Littleton, one of our first speakers, is already sitting there full of energy and ready for action. So the topic today is multiple myeloma in Africa, collaboration for early detection and registries. And I'm sure many of you have heard about all the wonderful things that is taking place and happening around the region, sub-Saharan Africa, with multiple myeloma. And for those who don't, we will inform you today. So today is going to be a very interesting session with a combination of both very, let's say, detailed orientated myeloma diagnostic aspects, as well as some more public health type initiatives to see if we can improve the care and the detection of myeloma in our region. So if I can have the next slide, please, Gerdien, thank you. So please note that the recordings of the sessions can be found on the bloodsa.org.za websites, and you can look under resources, deep dive. Maybe you can have a quick look now just to see where they are. I have to say there's fantastic uptake. I looked at the data today, and it's impressive to see how many people have already been coming to the website, looking at the videos. So thank you for the support from this group as well. Please add any questions or comments to the chat. We want you to be engaged, part of this. It's our meeting. It's really a joint meeting for everyone in the country where we try to do something special together. So let's talk. Not that I think we need a lot of encouragement. Usually there's great discussion. We will have time for that later. Then CPD points for South African HPCSA registered attendees. These are automatically submitted to the HPCSA when you register and you put in your registration number. That will happen. If there are any other questions, please contact Melanie Davids. Next one, Gerdien, thank you. Next slide. Right, so here's the people we want to thank for the organizing: Professor Estelle Verburg, Gerdien Kritzinger, Melanie Davids, who work very hard behind the scenes to make this happen. And we're really thankful for that. And then, well, you can see the welcome introduction is being done as we speak. And we can go straight on to our first speaker right on time. And it gives me great pleasure to introduce Dr. Neil Littleton. Neil has been a colleague that I think I've known for 20 odd years, probably almost 25 years. And Neil is one of those people who show us how to do the impossible. He's the head of hematology in the Eastern Cape province, and he's been there pretty much alone in the PE region as clinical hematologist. I've heard and seen some great medical officers that's worked with him, that's come around, that's been unbelievably well trained by him. But Neil, how you do it and what you do is incredible. And beyond the fact that he's so busy, Neil is also the one who pioneered the first NGO in blood diseases, the Ghazi Foundation, which is very much focused on educational and infrastructure outreach program. And they've done great work, and we've asked Neil to share some of that with us today. So thank you, Neil. The next 5 minutes are all yours. Over to you. You're welcome to share your screen.
Okay. Thanks, Vernon. You flatter me. Right. I think the story of Igazi is, as Vernon alluded to, perhaps maybe the story of my journey to the Eastern Cape. Because when I moved to the Eastern Cape from Cape Town, in fact, there was no hematology in the Eastern Cape. In fact, I had to tell the superintendent what a hematologist was. So it was, they didn't know what they were getting, but they were happy they got it, but they weren't sure what I'm doing and stuff like that. In fact, my first meeting with the superintendent was to say, "Hi, I'm Neil Littleton. I'm easy, but I'm not cheap," referring to the medication that we use. And that took some time for it to sink in with him. But it was not an easy road to travel, because in 2006, when I got there, I was put literally in a filing room, and that was where I had to see all my patients, and we were giving chemotherapy and blood transfusions in the passage whilst all the other patients sitting there, and magnanimously given 2 beds in the oncology ward. So it was quite a challenge to get there. I mean, moving from the Western Cape, where things happen, you just open your hand and then things get given to you. You come to the Eastern Cape, and so I'm sure it's similar in many of the other less idealistic provinces. And I'm sure if anybody's watching this from those provinces, they would agree with me. So the whole idea was to try and get government to build something for us, but we were just hitting a brick wall the whole time. And I was sitting with a patient, a private patient that I sent for transplant, and saying, we need to do something for the patients, the state patients in this province, that they can get treated locally and not have to go to another province with all the bells and whistles. And then why can we not do it here? And I'm the kind of person who just does not take no for an answer. So we started going around, but there just weren't any NGOs who could assist. CHOC was more for children. Cancer, well, never saw them. There was just nobody at that time. We're talking about 2006. So we had to start our own NGO. And why? Because if you want to start getting attention from government, you need money. And if you need money, you need a bank account. And you can't put it in your own bank account because that's corruption, and we don't want to go there. You need to have an S18A certificate so that you can give them a tax refund. You need to be BEE compliant. There were so many things that one had to learn at a very short notice. So what I did was I empowered myself with people around me. And I got 3 patients who were transplanted. One was a retired judge. The other one was an architect, but I didn't use him. I used his wife because she was very painful and very, very particular. She was head of the Orchid Foundation of South Africa, so she knew how to run an NGO. And then I had a guy who was financially qualified. So you have to empower yourself with people around you. And probably the most important person was my spouse, Cole, who is just a dynamic person and an absolute energy support system, and just pushing. So we eventually got the foundation started in 2008 with a few objectives. The first objective was to build a unit for the Eastern Cape, and I'll get back to that shortly. The next one was to do outreach into the Eastern Cape, and then patient support, because you send a patient off to Cape Town, Groote Schuur, and they get their transplant, but they have to stay, or their sister or their mother or the donor, and where do they stay, who's going to pay for it, etc. So we had to support these patients. Education was important, and here we did GP education to get early diagnosis, so that you don't get patients presenting to you in extremis. You want to get the patient diagnosed earlier. So we started doing GP early detection conferences where we went around the province, especially the rural areas, and it was so welcomed by the GPs over there. I mean, have you heard of GPs driving 300 kilometers to come to a meeting? And this is what they were doing. And it's so successful, we started doing it in the other provinces. We did all the provinces except Limpopo. In fact, we were even going to go international to Mauritius, but then unfortunately COVID stepped in and that came to an end. We also started doing nursing training because there aren't enough nurses doing hematology. So if you can start getting nurses interested in hematology, maybe you can ignite a fire there and that they would go further. So, but I think Caroline's going to speak about that now. Now, I don't want to take her fire away. And then we also did community training, and we trained patients and community members to go out to the community to educate patients or the people about early cancer signs. And that was very, very well received by the communities in the greater Port Elizabeth area and the Eastern Cape. Furthermore, because of this high incidence of hematological malignancies in this area, we started doing environmental testing of the water and the air, and we found high levels of tritium in our groundwater. And that we were taking further, but that's another story. Another problem we found was not enough donors on the registry, especially people of color. And so we initiated the Maro Masakani movement. And this was then taken over by, at that time, it was the Sunflower Foundation. And, we stimulated them to start testing people of color again. Very importantly, what Igazi does for me is the ward wellness. And do not think for 1 second that our illustrious government is going to look after our units. You have to do it yourself, and that costs money. So all our cleaning materials, X-ray machine I bought, even a bedpan washer. We had a serious outbreak of Pseudomonas, and we found it on our bedpans. We didn't have a bedpan washer, so we had to buy one. Our chairs that the government gave us in the outpatients, well, they didn't last, so we had to buy NASA accredited chairs for our patients. But getting the ward, that was really, really a tough one. Because it went round to national, I heard via that national said, but why does the Eastern Cape require a hematology unit? Now, when you're dealing with that kind of thought processes, you're just hitting a brick wall. So what we did was we did a myeloma transplant back in 2008. First time a transplant's been done in the Eastern Cape. We did it on the balcony of this oncology ward, which when I say it's an oncology ward, think back in the movies of the 1960s where you see pictures of these leper colonies with the beds. And then you've got this thick, what in Afrikaans we call it blauwdraad, a thick blue wire that's on the ceilings, and this K sheeting hanging from that, with those big brommers flying around and laying their eggs everywhere, and cockroach. And I mean, we had patients there who had stage 12 breast CA, bronchus CA with the trachees, and the cockroaches crawling in and around there. It was really, really disgusting. But that's what I had to do. So we cleaned the balcony very well, and we did a transplant, and it was successful. And then we had a big meeting, brought the press, brought everybody who was important, and we brought government, the MEC of Health for the Eastern Cape, the SG, and the Premier. And we had a big event, and we told the press, look what our lovely government has done. We've done the first transplant, and we made them look good. And they were so enthralled with that they said, yes, Neil, we will build you a unit. Luckily for us, we had the press there, both Radio Algoa and all the newspapers, and we caught this, and then we kept the pressure on. It was a difficult time because you had to get the whole community of Port Elizabeth and the Eastern Cape behind you. You had to do radio interviews. You had to do fundraising. Every weekend was fundraising to make money, because you can't catch our government's attention without money. It was really giving up all your free time for something that you believe in. And we did it. And we even had collaboration with Novo Nordisk, with the Hemophilia Foundation. So we became quite internationally known. We ran their program for 1 year. They were so enamored with us that they gave it to us for another year, which was tough, but we did it. But yeah, so we eventually got this unit going. We started treating our acute leukemias locally. We didn't need to send our patients to the Western Cape anymore. We don't need to send the patients from the north of the province to Bloemfontein, and we don't need to send the patients in the east of the province to Durban. We can actually start looking after our own people. We even started doing transplantation in 2016, and that's been going very well. We've got a very strong myeloma transplant program going. In fact, we've got one right now that we're going to discharge tomorrow. COVID. COVID was a tough time for Igazi. We didn't have much support for the Eastern Cape, for the Port Elizabeth hospitals. So in fact, Igazi ended up buying PPEs for the doctors. So because there were just no PPEs. In fact, we found out that it's cheaper to make your gowns. We got a whole lot of sewers, seamstresses and seamsters to make gowns for us. We paid them 75 Rand per gown, and that's what we had to do to survive COVID. We were also recognized by government for our work, and they invited us to be onto the Presidential Committee for NHI, which opened a lot of doors and a lot of contacts. So yeah, so of all the objectives that we set out in the beginning in 2008, we have ticked off all of them. And we are now moving to a new period of Igazi, where Igazi is going to go more national. It's going to move to the Western Cape. I believe Caroline's going to speak about that. Some things I can just say that we have achieved is we supported the outreach for me into the Eastern Cape to Frere Hospital, to Umtata, to support the unit at Frere, buying furniture. Caroline did amazing work at King Edward with the chemo room there that refurnished it, redid everything there. She made the money herself, and she used it wisely and rehashed and redid the whole King Edward chemo room. So yes, it just shows what you can do if you want to do it. It is a lot of hard work, a lot of dedication, commitment. If there are any youngsters, any pioneers out there listening who feel, okay, I'm going to do this, I'm going to go to another backwards province and see if we can do it, I must warn you, you are in for a rough time, but it is rewarding. I'll take questions on it, but yeah, I think I've basically covered everything. But thanks to that, we have GPs who are aware of hematology, and we've got a fabulous transplant unit going right now.
Neil, yeah. Wow, what an inspiring story. This is amazing. Thank you. See, I did not flatter you. I just spoke the truth. I actually didn't even speak the whole truth. So it is truly, truly inspiring. I think we're going to keep the questions for the end of the session, just in the interest of time. But please, if you have any comments, thoughts, questions, put it in the chat box along. And just to say one thing, there are at least 3 provinces without any clinical hematologists as we speak. So please, there's a huge need in South Africa. We definitely need more people like Neil. Right, our next speaker is Professor Estelle Verburg, who is the CEO of Blood SA, and who will speak to us about the Bristol Myers Squibb Foundation Global Cancer Disparities Africa program. And yeah, so our unit is very much involved with that, as is many, many units around the region. I think most of whom are represented here or are in the audience today. Thank you for coming. And Estelle is going to tell us a little bit more about that. Estelle, over to you.
Thanks, Vernon. And our engagement in this program, as so many things in my professional life, found its origin with you, or its sort of point of contact with you and with your leadership. So let me make that clear. And Neil, I know that you may have to run to do other work. It would be great if you can stay. But I just want to tell you we got you today. I wanted you to speak and you were not really wanting to, but I think we're going to transcribe that talk and we're going to write some of those things down and we're going to post it on our website and link to yours or the other way around. You have done all those things and many more. And it's exactly pitch perfect for this meeting today, because that's reality. You know, you sometimes say to me, we're in a champagne bubble in Cape Town, but you know what? Nobody can live on champagne. We need pure, wholesome water every day. Every one of us. We need the truth. We need reality. We need to engage with reality. And that is the point of today's meeting. Today's meeting is really about the reality of living in Africa, loving this continent, reaching out. And I cannot say enough what an inspiration you have been to us. And yeah, words really fail me. I am not going to take up too much time to speak about the collaboration. I think actions speak louder than words. Thank you for everybody who's here, people from private, from all centers, from PATH, from clinical, and also our African collaborators. And I'm going to make it very quick. And thank you, Khadin, for this kind of view. What we can do, I don't know how it works really, but we can try to, as we speak and introduce some of our collaborators, I can't see all of them, and today was truly just to start the ball rolling. But they can put on their, I think everybody, let's do this. Everybody who is part of the BMSF Myeloma collaboration, who's a partner in that. There are some of the PIs in the meeting. Would you mind putting on your videos? I don't know what the effect of that will be, if everything will be seen, but it will be great if everybody will just put on their videos. Great. That's fantastic to see. There's Moses. Oh, Kicha, that's great.
Just you put your view on gallery view, then it's very nice to see everyone.
So this is amazing. Wow. Yes, everybody from all the units that are connected, please put on your videos. That's great. Yes. So even if you are, we can even speak to the students in these units, because let's just get everybody who's involved in this. And some of the students, there's also Romana is in the meeting, and Romana is also is also one of our BMSF fellows. So please, so let's see everybody. That's really great. So I think, you know, in this meeting, we can all be ourselves. We sometimes bungle a bit. We can't get the recording going, or, you know us. And I hope that we will never lose that touch, because it's really about normal people. It's about, you know, it's just about us trying to do our work and trying to do something great. So something that will impact patients. And so Cameron is, I'm touching upon Cameron's name here. He's going to speak today, and he's also going to be part of this myeloma collaboration as part of UCT. And I see also Gideon is here, and Ruder from Free State, he's also a new fellow. So I'm just going to, you know, point out a few people as we go on. It seems those who have put on the videos is on my side. So let me quickly start at the top, at Eldoret, and Dr. Letodo. So we just want going to highlight you. On my screen, you're on the top right, but you may be in different places. Hi, Teresa. So I've checked where Eldoret is. It's, at least we will understand this, it's at the northeast of Victoria, Lake Victoria. Am I right? It's up there. Sort of.
Yes,
it's not,
yes,
yeah.
yes.
And that's, everybody understands that, where Lake Victoria is. And Teresa, I don't know who is there. Do you want to point out other people in the meeting that's also part of your group?
Professor, unfortunately, I'm the only one from my team joining the meeting today. Today being a Monday, it has been a bit heavy. We usually have our multiple myeloma clinic and hematology clinic today. So I think some are still running late. And then Mercy and Dr. Beatrice had to join another meeting which had been scheduled earlier. So I think I'll be representing them, but just to say we are grateful to be joining the rest of the team today. And thank you for inviting us.
Thanks for coming at such short notice. This was a very, very quick meeting we put together very quickly in the last few days. So it's great to have you here. And the whole point is we're all busy people, you know, and we're here and we're working together. So that's great. Then at the south of Lake Victoria is the other partner, but they've not been able to make the meeting today, as far as I know. And that's Catholic University of Health and Allied Sciences in Bugando. And so we've got partners there that we will be working with in Tanzania. And then let's go down from there, Zim, of course. So Dr. Chazambutsa, Moses, great to see you. And I see you've brought a few, I think you've brought one or two of your collaborators with you. You are 5 partners in Zim, and we'll get to know all of you as we go on. That's great. And then Tebogo, Ms. Titi, very soon to be Dr. Titi. So Tebogo, hello, welcome.
Hello.
And you are working with Jacques and the team. Jacques is in a what is it, exam meeting right now, so he'll be with us soon. Oh, I see Gilta from Zim too. Hi, Gilta. It's great to see you. And yeah, hello, Gideon, who's also going to be joining them soon. And then we've got Jonathan here. I don't know, it seems that some of the other fellows are not here today, but we saw some of the other, like Caroline and yeah, we saw Lillian, who's from Uganda, in our office together with our one of our pathologists, heme pathologists just now. So basically what today was about is just showing we're human beings, we people, we are busy, we're running around, and we meet together, and hopefully in the next year we can move ahead. There's one more person I just quickly want to introduce. Jonathan, where are you? There's our Jonathan, obviously, Jonathan Oxland, who's been with us for a long time. But then there's John Watts. I don't know if you can put on your video. John Watts is a young doctor who's who started work with us actually today, and he is going to help us and reach out to partners in the coming year. So that is the plan, that we can start working with everybody. So that's that from my side. I hope that made you think of what's ahead for myeloma. We hope that it will be something that covers public and private, that we can do things together. And the beautiful thing of all these partners, it's always patient-centered. It's about early diagnosis. It's about really getting hematological malignancies on the map. And that's what Alejandro is going to speak to us. We saw his beautiful bio on our invite. So he came to us, he grew up in California, came to us via the BMS Foundation as a volunteer, as their, intern, as their intern. He's been energizing us to start working on education and early diagnosis in new ways and innovative ways. So please tell us more, Alejandro.
Of course. Thank you, Estelle, for that introduction. I'm just going to go ahead and share my slides now. Okay. Are you guys able to see the slides just fine?
Yes.
As a yes. Okay, perfect. Thank you so much. So yes, as Estelle was saying, Prof. Estelle, my name is Alejandro Nava. I received my doctorate of pharmacy from the University of California, San Diego, went on to do a clinical training at the University of Washington, and now I have the privilege of being the Bristol Myers Squibb Foundation Public Health Resident. A part of that allows me to work within Southern Africa, and I've had the opportunity to work with oncologists throughout the region in Ethiopia, Lesotho, Eswatini, and of course, South Africa. For the past 3 weeks, I've been working with Prof. Estelle and her blood assay team, and it's been an amazing opportunity. And I would like to take some time to give a short presentation just to talk about some of the lessons that I've learned and share those with you. So without further ado, I'll go ahead and start. We're going to be talking about the patient's journey to a multiple myeloma diagnosis. Our outline for today will include the epidemiology surrounding multiple myeloma, and then we'll segue into understanding the patient's journey of a multiple myeloma diagnosis. So the lifetime risk of humans developing cancer is placed by many studies to be above 30%. And that's at least partially due to the association of increased longevity. Specifically within South Africa, reports mention that about 9.2% or 5.51 million South Africans are over the age of 60 years, and this proportion is increasing. So plasma cell myeloma is a subgroup of plasma cell neoplasm and is associated with substantial morbidity and mortality. The incidence is highly variable, but has increased uniformly since the 1990s, with the largest increase in middle and low-income socio-demographic index countries. Factors informing this change include population growth, an aging population, and increased age-specific incidence rates. So data from the Global Cancer Observatory shows the incidence of myeloma to be the second most common hematologic malignancy in high-income countries, as portrayed by the graph to the left, which shows an incidence range of about 4.5 to 6 per 100,000 annually for more affluent countries. The graph to the right compares the incidence of myeloma to mortality among the same countries. And taking a closer look within the region, Southern Africa, incidence appears to be lower in sub-Saharan African countries, but these numbers may be significantly underestimated as described in a paper. So, sorry about that, there's just a little bit of lag here. There we go. So with that in mind, what do the local studies tell us about the incidence of myeloma? Well, a study by Schnaufeld et al. Investigated the incidence rate of pathology-confirmed adult cases of all hematologic malignancies reported to the National Cancer Registry between 2000 and 2006 by age, gender, and population group. The study found that incident rates were generally 20 to 50% higher among males. Myeloma's crude rate was 0.7 for males and 0.67 for females per 100,000 persons annually. Myeloma's age standardized rate was 1 for males and 0.83 for females. Similar incidence rates were found by earlier and subsequent regionally focused studies. So these numbers provide us a clearer picture of myeloma's disease presentation in the region that we're working in. So with this understanding, where do we go now? Well, the current global health policy and research priorities in myeloma are the following: to improve diagnostic and treatment capacity, ensuring affordability of effective medications, elucidate underlying etiological factors, heterogeneity in myeloma incidence, and of course, earlier diagnosis. But of course, these priorities are easier said than done, and I would like to now focus our attention to learning about what many myeloma patients go through before being diagnosed with the disease. So multiple myeloma, it's an elusive diagnosis. Patients with myeloma have one of the longest time to diagnosis intervals among cancers, with some studies showing an average time between symptom onset and multiple myeloma diagnosis of 99 days. Compared to patients with other cancers, they also have the most repeated consultations occurring in the primary care before referral to specialists, often experiencing 3 or more repeat consultations. Patients often have multiple and/or severe symptoms that can be diverse and similar to other self-limiting conditions. These symptoms may include, for example, a combination of fatigue, bone pain, confusion, and dehydration, which are often initially attributed to some other condition or normalized by the patients themselves. More so, multiple myeloma symptoms can be vague and nonspecific in onset or intermittent. But unfortunately, these nonspecific symptoms are attributed to myeloma's proliferation of plasma cells and propensity for bone destruction, which are captured in the 4 key domains of myeloma-associated end organ damage, which includes hypercalcemia, renal insufficiency, anemia, bone lesions, and this is often abbreviated as the acronym CRAB. So I had the opportunity to work with Noma Liso, which is a social worker for the 5E hematology unit. During this time, we conducted interviews with patients and asked them to recall their pathway to the myeloma diagnosis. And this is what our patients were saying. Before my multiple myeloma diagnosis, I ran marathons. When I started to experience bow pain in my lower back, I thought it was associated with my training. So I thought nothing of it. It wasn't until things got worse and my wife's sibling, who is a doctor, told me to get the pain checked out that I was eventually diagnosed with multiple myeloma. Similar to the interviews that we conducted, a study by Howell, D.A. et al. Conducted a qualitative study to examine events leading to a multiple myeloma diagnosis by asking patients about their experience during this time. Their patient accounts often suggest that they believe their general practitioners did not initially tend to consider their health changes as indicative of multiple myeloma. For example, their patients mentioned that when pain was associated to be mechanical, analgesics and anti-inflammatories were commonly prescribed, often with advice to consult a physiotherapist. We also saw a similar event occur in one of our patients. They recalled the following. I was referred to a very good physiotherapist by my general practitioner. He charged me a lot of money to fix my bone pain, and I often left these sessions with more pain than when I came in. This was mentioned by one of our patients on the 5E clinical hematology clinic. So myeloma is a unique cancer because basic diagnostic testing relies on investigations that are broadly accessible across the spectrum of global health services and can provide at least the key CRAB criteria to alert healthcare providers of an underlying myeloma disease. Of course, there are other techniques such as bone marrow or tissue histology that can provide confirmatory diagnosis, but are found within the secondary and tertiary care setting. But unfortunately, even with confirmed CRAB criteria laboratory testing, the diagnosis of multiple myeloma can still be delayed. So in a population-based cohort study by Seeger et al., the team looked at the electronic health record of 17 million patients from 2006 to 2016 within a UK database. Their aim was to characterize the frequencies at timing of clinical features in the primary care setting prior to a multiple myeloma diagnosis. So let me just go ahead and orientate you to this graph right here. So on the x-axis, we have the days before a multiple myeloma diagnosis to the far right. And each one of these little icons represents the different CRAB criteria that we spoke about earlier. Their confirmatory category of what is confirmed to be a CRAB criteria is right here in the smaller print. So This study found that the median time between date of confirmed renal impairment or anemia and date of multiple myeloma diagnosis to be 58 and 73 days, respectively. The median diagnostic interval between a confirmed hypercalcemia and multiple myeloma diagnosis was only 23 days, while the diagnostic interval of 105 days occurred between confirmed imaging results of bone lesions and a multiple myeloma diagnosis. This presentation has pointed to two major problems. First, general practitioners are faced with the task of differentiating abnormalities that may indicate cancer from those of non-malignant conditions and making appropriate, timely referrals to the secondary care. A solution that our team is working on is to provide general practitioners with a diagnostic pathway that can assist in accelerating disease diagnosis. Secondary, the primary literature shows that before diagnosis, a lot of patients are unaware of what multiple myeloma is. A potential solution to this is to promote awareness surrounding multiple myeloma and its symptoms. At the same time, we can also encourage patients to recognize what is normal for them and seek help when a new change in their body is detected, or when they notice progressive deterioration in their ability to perform their usual activities. And finally, going forward, our ultimate goal is to implement a multiple myeloma registry among different locations in sub-Saharan Africa. This will provide healthcare professionals with real-world picture of disease presentation, current treatment practices, and outcomes, which will also allow for the implementation of qualitative studies to understand gaps among patients, healthcare providers, and health systems. So with that, I'd like to thank you for your time and for your attention, and especially thank you, Professor Estelle, for allowing me to be a part of your team and to work with you for the past 3 weeks. Diana, thank you so much for your help with putting up the epidemiology slides. And of course, to the Blood Assay team, Nomalisa, thank you for enduring me for the first week of your time. And of course, to the staff at the 5E Hematology Unit, thank you for your time. And here are my references.
Alejandro, thank you so much for your wonderful presentation. That was really great. Again, in the interest of time, I'm going to let the Q&A stand over till a little bit later. I have to apologize to everyone. There seems to be a challenge with Zoom for some or other reason that we will figure out. Zoom has limited us to 100 participants today, and many people have been struggling to come in. So fortunately, we are all by now technical digital natives, and I would like you to have a quick look in the chat box, and you'll see a new Zoom link that is there. Please quickly copy that, take note of the code, all in small caps, and put that into your browser address as soon as this meeting has been stopped. Then we will just give everybody else a chance. We'll also email the link to everybody that is on the email list. So if you're struggling, just go and look at your email, and because many people want to come in and they can't. So we're quickly going to do that. Let's see each other back in the new meeting in the next 60 seconds. Right, let's see how quickly we can get everyone back here. Thank you. So Cameron, if you can share your screen, and I think the chat box might be disabled on the webinar function, which means that anybody with questions or comments, just put those in the Q&A section at the bottom. So you can see there's Q&A at the bottom. You could just type your questions or comments in there. Thanks.
Prof, I have no option to share my screen.
Right, can we hear Gardine?
Sorry, let me just host and panelist. I'm on it, Cameron. Let me just, it should work now.
You are learning on the job, Gardine. That's great.
Indeed, under pressure.
We are learning as we go along.
No pressure.
But it's as I say, we're trying to keep it real. It's just the only thing that makes me very unhappy is not being able to see the people. So Cameron, seems you are
There you
great.
go. Okay.
Fantastic.
There we go. I'm still unable to turn on my video. So I'm sorry for that. You can
Right,
imagine how I look.
allow me to just introduce Cameron quickly. So Cameron, I actually saw your video a second ago, so something was happening. So maybe you could look into that. But Cameron Francis is a chemical pathology registrar at the UCT NHRS, and he completed his undergraduate studies at the University of the Free State in Bloemfontein, and after spending some time in hematology in one of these community service posts in the NHLS, he saw the light and thought that pathology was his direction, and eventually went into chemical pathology. So Cameron is a great person. He's got very interesting work that he's doing in machine learning and artificial intelligence as well, and the application thereof to chemical pathology and potentially hematology. And he gave this talk to us, and afterwards I said this was so great. I really wanted this to be shared with everyone around the country. So thank you, Cameron, for agreeing to do this for us. Welcome.
Thank you, Prof, and thank you everyone for allowing me to give you this talk. As Prof mentioned, my name is Cameron. I'm a second year chemical pathology registrar, but I've been sort of in the pathology field for the last 3 years, including my community service time. So this talk is going to be fairly, I'll try to keep it as basic as possible. And the main goal is really to help everyone develop a basic understanding of serum protein electrophoresis, so that the comments that are put out by us in chemical pathology can be more easily interpreted by the people who need to make use of the reports. So in order to understand the comments, I will have to talk a little bit about the method, which can be a bit technical, but it shouldn't be too long. Then I'll talk about some of the applications of protein electrophoresis other than serum protein electrophoresis. I'll talk a little bit about proteins, and then we'll go through some different patterns and interpretations. And then lastly, I'll touch on immunofixation, and then a little bit about pricing. I know we have sort of gone a little bit past time, so I will try to keep it short and skip through a couple of slides if necessary. So this is a fairly standard serum protein electrophoresis comment, and I'll read it out. Albumin is normal, alpha 1, alpha 2, and beta 2 regions are elevated. The gamma region measures 24 grams per liter in the reference interval provided. And before spending time in chemical pathology, all of this would have been gibberish to me. And I'm sure it's gibberish to many of you on the other end of this call. And so although SPE comments aren't standardized amongst all laboratories, this is sort of a fairly generic thing that you might see. So hopefully by the end of this, everyone will be able to understand what this comment means. So a little bit about electrophoresis. To break up the word, it always helps me to understand and remember things by sort of taking words apart. So electro refers to electricity, which is essentially a form of energy resulting from the existence of charged particles, which is important, either statically as an accumulation of charge or dynamically as current. Phoresis means delivery or movement of a substance by means of an agent. And this is different to pheresis, which means to take away or separate. And this is sort of the term that you'd use in your apheresis procedure that you do in hematology. This is a picture here of a man, Arne Tiselius, who developed the first protein electrophoresis machine in 1951, for which he was awarded a Nobel Prize for chemistry. So electrophoresis, now after having broken up the word, essentially means the migration of charged ions, which are essentially charged molecules, within an electrical field. This separation occurs based on the inherent electrophoretic mobility of an analyte. This electrophoretic mobility is directly proportional to the net charge and inversely proportional to the size of the molecule and the viscosity of the electrophoresis medium. And I'll talk about what all these terms are a little bit just now. But essentially, the stronger the charge, And the smaller the size, the faster a molecule is going to move. Now, proteins are charged macromolecules. And this charge essentially comes from the ionizable amino acid groups. And this ionization, the net charge, can be manipulated depending on the surrounding medium's pH. So this makes proteins a really good candidate to evaluate using electrophoresis, because we can manipulate numerous factors sort of around them to best separate them on an electrophoresis. So the different components of electrophoresis, you can see, let me just put on a laser pointer quickly. Laser pointer. So this top image here, we've got a labeled diagram of the basic components. So we've got a power supply that will provide a constant current or a constant voltage, depending on the type of machine that you're using. Then we have these buffer wells over here. And the buffer is important to carry a voltage and to fix the pH. So I mentioned in the previous slide that proteins can have their charge manipulated depending on the surrounding pH. And so this keeps that pH constant. So it keeps the proteins sort of charge constant. Then 2 is basically an electrode that carries a charge from our power supply into our buffer solution. Number 3 here is a support medium in which the separation will actually take place. And this connects the 2 reservoirs together. And then in some systems, you have this number 4, which is essentially a wick or a salt bridge connecting your buffers to your medium. And then 5 is just a protective cover over the top, which prevents evaporation and prevents anybody from shocking themselves when they touch the inside of the apparatus. So zone electrophoresis, which is what we're going to be talking about predominantly, refers to the migration of charged molecules of proteins, usually in a porous supporting medium, such as an agarose gel, so that each protein zone is sharply separated from a neighboring zone by a protein-free area. So here you can see sort of a darkened area followed by a sort of a protein-free area, followed by a darker area. And so each area is sort of clearly delineated by a protein-free area. We form these zones by staining with a specific protein stain that will produce what we call our electropherogram. This scan over here can be put through what we call a densitometer, which can basically read the amount of light that gets absorbed by this gel, and we can then output what we call a densitometric scan. And this is what we generally look at nowadays as technology is moving forward, and we'll talk about that in the next slide. So this here is a capillary zone electrophoresis machine. And this works slightly differently to what I described earlier. Instead of a gel medium, we instead have a capillary which carries our sample. And this capillary can withstand much higher heats. And so we can use much higher voltages when separating our proteins. And this allows us to run samples much more rapidly and allows us to automate this assay much more easily. Essentially, instead of getting a gel output, we have a lamp on one side of this capillary and a detector on the other. And as proteins pass through here, the amount of light that gets absorbed gets read by the detector, which outputs into a picture that I'm going to show you now on the next slide. What's quite nice about the capillary zone electrophoresis is that it's got the same sensitivity as the gel electrophoresis, and all of the information can be stored digitally and used for other applications in a digital format. So this is what a capillary zone electrophoresis output will look like. And it's fairly similar to the densitometric scan that you'll see that we can obtain from the gel electrophoresis. And we break it up into 6 different zones: an albumin zone, alpha 1, alpha 2, beta 1, beta 2, and gamma zones. And from this, the reverse of the gel electrophoresis can be derived. So in this top right corner here, you can see sort of a little digitally produced gel scan of this graph. So where do we use electrophoresis in a chemical pathology laboratory? It's not only for serum protein electrophoresis and monoclonal immunoglobulin detection. We also use it for CSF fluid identification. So we can identify a molecule called beta 2 transferrin in in fluids, which can confirm or refute a diagnosis of a CSF leak. So beta-2 transferrin is a protein that's only found in CSF, and so patients who have had traumatic sort of head injuries or have rhinorrhea after neurosurgery, that fluid can be sent to us, and we can find this protein on a CSF electrophoresis. We also separate out lipoproteins and classify lipid disorders into the Fredrickson classifications using these agarose gel electrophoresis. We can also do lipoprotein polyacrylamide gel electrophoresis, which basically is using a different gel medium to this agarose gel. And here we can separate particles by their size. So we can determine LDL particle size and HDL particle size and so on. And then we also use electrophoresis for molecular diagnostics. So protein electrophoresis is why we're all here. And so it's important to know when and why to do or order an SBE. And essentially any of the CRAB criteria that were described in the previous talk, if the patient presents with any of those features, a wide globulin gap in a patient who can't explain it. A globulin gap is essentially your total protein minus your albumin, and that sort of gap is mainly made up by immunoglobulins. Peripheral neuropathy for patients with conditions such as POEM syndrome, and then myeloma staging. There's also a couple of other conditions that are associated with monoclonal gammopathies, like certain allergy-related conditions and so on, but I'm not going to be talking about those in this talk. So just to touch on the myeloma staging, SBEs are required for the to classify patients sort of who have relapsed from complete remission, whether disease is progressing. So an increase in size of 25% or 5 grams per liter, and an M spike or a monoclonal protein indicates progressive disease. A 50% reduction in a peak indicates a partial response. And if you can't see it at all on an SBE, but you can still see it on a fix, then we call that very good partial response. And if you can't see it on immunofixation on serum or urine, then we call that complete remission. So what I'm going to do now is I'm just going to briefly go through the different protein fractions. I'll keep this very quick, but it is important for when interpreting the SBE comments. So if I go quickly back to this slide over here, I spoke about these 6 different fractions. And albumin is fairly descriptive, but alpha-1, alpha-2, beta-1, beta-2, and gamma don't really mean much by themselves unless you have some insight or knowledge into what is actually migrating here. And so essentially alpha-1, the predominant protein there is alpha-1 antitrypsin. Alpha-2, the predominant proteins are alpha-2 macroglobulin, haptoglobin. Beta-1 is transferrin. Beta-2 is complement and IgA, and gamma is immunoglobulins. I'm briefly going to go through what these different proteins do and when they might be increased or decreased. But before I do that, it's important to understand the concept of the acute phase proteins. So acute phase proteins essentially refer to proteins that have a change in their steady state concentration as a result of infection or injury. So that means that it's a protein that can either increase its concentration or decrease its concentration when there is an infection or injury or essentially inflammation. So albumin is a negative acute phase protein, so it decreases in the setting of inflammation. It's synthesized by the liver, and its essential functions, or its 2 most predominant functions, are to maintain colloid osmotic pressure and the transport of molecules that are not water soluble. I'm just going to go over all of these fairly quickly. Alpha-1 antitrypsin is a protein that is synthesized by the liver. It's an irreversible inhibitor of elastase. It is a positive acute phase protein, so this will increase in inflammation. And the most common cause of decrease is liver disease, but genetic alpha-1 antitrypsin deficiency is also I think it's on my video now. Should also be considered, especially in pediatric patients. Alpha-2 macroglobulin, so this is quite an easy one to remember because it migrates to alpha-2 and it's a big protein. So 720 kilodaltons big. So I always use albumin as my sort of orientator to protein. So albumin will always migrate to the anode in most electrophoresis applications. And it's quite easy to remember. If you just remember one protein, albumin is 66 kilodaltons big. And so this protein here is more than 10 times as large as albumin. So it's very big. It's a protease inhibitor. And essentially, alpha-2 macroglobulin is upregulated or increased in nephrotic syndrome to help to maintain the plasma oncotic pressure. So even though you're losing all your other proteins, your body will know to create all of this large protein that will be retained by the kidneys and still be able to maintain some oncotic pressure. So if you ever see a raised alpha-2 in your or a very, very raised alpha-2 with a low albumin on your SBE, that's a clue towards a nephrotic syndrome. Haptoglobin, most of you should know about. It's a hemoglobin binding protein synthesized by the liver, and this migrates to alpha-2. It's also an acute phase protein. Transferrin is the iron binding protein in plasma. It's a negative acute phase reactant. It migrates to beta-1. It would be decreased in iron overload and increased in iron deficiency. An important application that we have for transferrin is carbohydrate deficient transferrin, which is also an electrophoretic technique. And essentially, transferrin has about 6 glycosylation sites. And in chronic alcohol abuse, the acetaldehyde, which is the one of the middle products of alcohol metabolism, inhibits the glycosylation of transferrin. And so these patients have a tendency towards asiallo and monosiallo transferrin. So basically means they've got less glycosylation of their transferrin. And this can be used to investigate chronic alcoholism in patients that you're concerned about. Complement, or C3, specifically migrates to the beta-2 region. And so C3 is basically a converging point of your entire complement system. And so when C3 is increased, your beta-2 region would also be increased. And then lastly, immunoglobulins, the star of the show. These are synonymous antibodies produced by plasma cells. And essentially, their role is to opsonize molecules for removal by phagocytes to inactivate viral bacterial particles and to form immune complexes. And in the event of monoclonal plasma cell proliferation, such as myeloma, then we will see a clonal immunoglobulin on our protein electrophoresis. So I'll show you what that looks like in a little bit. But first, just a quick summary of the acute phase proteins. So we said alpha-1 antitrypsin, haptoglobin, complement. I didn't mention ferritin and CRP because we don't really see them on the SBE, but they're just here for completeness sake. So these three are positive acute phase proteins, and our negative acute phase proteins are transferrin and albumin. So going back to our protein electrophoresis, if we've got albumin here, alpha-1, alpha-2, beta-1, beta-2, and then gamma, when albumin is decreased, that's often a sign of inflammation because it's a negative acute phase protein. When alpha-1 is increased, that's a sign of an increase in alpha-1 antitrypsin, which is an acute phase protein. So that's also a sign of inflammation. Raised alpha-2 can also be because of inflammation, because of the raised haptoglobin, but it can also be raised in nephrotic syndrome. Beta-1, we would normally expect to decrease because transferrin is a negative acute phase protein. And so generally, when beta-1 is increased, that can either be due to iron deficiency with a raised transferrin, but oftentimes we find IgA monoclonals migrating here. And so oftentimes when you have a beta-1 that's increased on SBE, we investigate further with an immunofixation. And then beta-2 is where complement migrates to, and so in inflammation, this will be increased. IgA can also migrate here. And so if this is very peaked, then we will sometimes also do an immunofixation. And then our immunoglobulins, we'll talk about just now. So looking through a couple of patterns, this is what our capillary zone electrophoresis output looks like. And essentially, as with all patient-oriented tests, from X-rays to full blood counts It's always good to make sure that you've got the right patient, the right dates, and all of those things. I've removed the identifying details here, so we can't do that. But it's just an important point to always make. And essentially what we have here is a normal tracing of our different proteins, protein fractions. And on the left here, you can see that we get a quantitative value for these as well. So here you can see that our albumin is 41, our alpha-1 region measures 3.5, and so on. And so we've got reference intervals for each of these different regions. And so when these are increased or decreased, we can correlate that back to these reference intervals. What is important to know, though, is that these values are not directly measured. They're all taken as fractions of our total protein value that we get off of our automated analyzer. So for all of these measurements here, none of them are as accurate as an automated or manual assay for these specific analytes within each fraction. So if you're looking for alpha-1 antitrypsin, then the alpha-1 antitrypsin assay is much more sensitive and specific than looking at an SPE alpha-1 region. So this pattern here, once again, the patient identifiers are removed, but here you can see that albumin is decreased, alpha-1 is increased. Here you can see the greater than or less than signs on the left. Yeah, so alpha-1 is increased, alpha-2 is increased, and beta-1, beta-2, and gamma are all relatively normal in quantity. But there is a small little irregularity here at the anodal side of gamma. So anodal just means more towards the left, and cathodal means more towards the right. I won't bore you with the technicalities of that. But a small little, what we call an irregularity. So the smoothness of this curve has been disrupted. And so this is a classical picture of acute inflammation. So we've got albumin being decreased as a negative acute phase reactant. We've got alpha-1 and alpha-2 being increased as positive acute phase reactants. And these small irregularities generally don't type as monoclonal. It's not impossible that there is a small monoclonal forming here, but generally these, we recommend that these FBEs get repeated in 3 to 6 months when a patient is in a less acutely ill state. So here we've got another patient, and once again, here there's a big pink spike jumping out at you, but always important just to sort of look at the patient and date and all those things first. And here we can see that albumin is decreased, alpha-1 is increased, alpha-2 is in the normal range, beta-1 is decreased, and beta-2 is decreased. And our gamma region is very much increased at 27 grams per liter. And you can see here that there's a large spike that's larger than our albumin, and that the rest of the gamma region outside of that spike is fairly flat if you have to compare that to this here, or this here rather. And so this here is what we call a monoclonal spike, an M protein, a paraprotein. There's various synonyms for this. Yeah, and so the next step over here is an immunofixation. And so essentially, an immunofixation will help us to identify exactly what class of immunoglobulin is migrating to this region over here. According to a study done by the Mayo Clinic, the distribution of diseases in patients with a monoclonal spike are that about 51% of them will have MGUS, but normally those spikes are less than 3 grams per liter. 18% of them will be multiple myeloma, 11% of them will be light chain amyloidosis, 4% of them will be lymphoproliferative disorders, and 16% of them will be other diseases such as solitary phagocytoma and smoldering myeloma. This study didn't look at other causes of monoclonal gammopathies, but solely looked at the hematological causes of the monoclonal gammopathy. So immunofixation and immunosuppression are, for all intents and purposes, the same thing. The method that we use is slightly different. In immunofixation, we form on a gel, or the sort of what I call the old-fashioned way. And immunosuppression is basically a very similar technique, but performed on the capillary zone electrophoresis. Now, the fundamental sort of methods for these are quite different, but the output is very much the same. The immunofixation is slightly more sensitive than the immunosuppression. And so we still retain both methods in our laboratory for cases where a monoclonal might be very small, or when there's uncertainty on an immunosuppression, then we'll do an immunofixation. But immunosuppression is much quicker to do, it's much cheaper to do, and it requires much less skilled labor. And so essentially what we do with immunofixation and immunosuppression is we add an antiserum to our sample, and that antiserum so we'll add 5 different antiserums. So we'll add an antiserum that will bind to an IgG, a different antiserum that can bind to an IgM, a different antiserum that can bind to IgA, and then to kappa light chains and to lambda light chains. And then essentially we will run each of those sort of bound proteins in a different lane or in a different vial, and then see if our migration, or if that monoclonal spike will migrate differently, or if it will stay into a certain part on our gel, depending on the method that we're using. And essentially what that does is it achieves 3 objectives. One, determines monoclonality. It determines the class or isotope of a heavy chain or a light chain. And it reveals monoclonals that are hidden or too small to see on a normal serum protein electrophoresis. And so it's not a test that can be requested by clinicians, at least in the public sector, but essentially it's a request that a reflex test is added by a pathologist when there is an indication on an SPE. And so we add one whenever there's an unidentified peak or band of restricted mobility, if there's a significant change in position of a known M spike or monoclonal spike, hypogammaglobulinemia. And so hypogammaglobulinemia essentially just means a decreased amount of gamma globulins or decreased immunoglobulins. And the reason for that is that a hypogamma may be caused by a hidden monoclonal on the beta region, or a very small monoclonal in the gamma region. That's likely just because the sort of monoclonal or malignant plasma cells are just overtaking the marrow and not allowing production of other immunoglobulins. The disappearance of a previously identified monoclonal peak, and that's for the staging of myeloma. A previous equivocal immunofixation, or this means an immunofixation which did not give a conclusive result, or if there's a compelling clinical history. So a patient with a hypercalcemia, or a patient with a pathological fracture and unexplained renal failure, and so on. So we look at the forms for every single SPE that's sent to us. And so if you have any patient that you are concerned about, it's always important to put a history on your form, because if the history is compelling enough, we will add an immunofixation regardless of what the SPE looks like, even if it is normal. So this is essentially an immunosuppression. And so I mentioned in the previous slide that what we're doing here is we basically add this antiserum to our sample and we run the protein electrophoresis again. And when that antiserum binds to that immunoglobulin protein, it changes its properties. So it changes its size and it changes its charge. And because those 2 parameters change, the migration of the protein changes completely. So this yellow line is our original tracing, and this blue line is our new tracing after adding the antiserum. And you can see now that this blue line here basically has all of this protein migrating to this region around albumin. And that's basically all of this antibody antisera complex that's migrating here. And it's no longer migrating to the original peak. And so we say that this is subtracted. And so here we can say that this is a monoclonal IgG. We don't have information on the light chain as yet, but this is the typical IgG monoclonal. Here's the IgA, and so here you can see that the yellow lines and the blue lines essentially look fairly similar. There's a little bit of subtraction there. That's likely just a little bit of normal IgA that's coming down. IgM looks very similar to IgA, and so you can see the blue line and the yellow lines almost sort of make it look like a green line here, because they trace each other so well. And then here's our light chain. So here's kappa, and you can see that this is also sort of forming almost an exact tracing. And then on lambda, you can see it looks fairly similar to how that IgG subtraction looks. So you can see that everything from this peak is subtracted and it's all migrating somewhere else. And so this here would type as a monoclonal IgG lambda peak. I'm just going to show you a couple more examples. So here is I don't have the values on the left yet, but here's a small little irregularity or sort of second peak in beta 2. And so this doesn't normally happen in inflammation. There are a couple of things that can interfere with our electrophoresis, things like certain antibiotics, contrast medium, fibrinogen, and so on. So samples that aren't sent in the yellow top tube. But generally, peaks over here that aren't sort of, to rule out interference or sort of interference versus a monoclonal, we'll do an immunofixation. But because this one was so small, we decided to do the more sensitive method of a gel immunofixation. And so this is probably the picture that you're all more accustomed to looking at from undergraduate books and so on. And here is our normal electrophoresis lane. And then each of these lanes basically has an antiserum added to it. And so when the sample migrates down here, when the antiserum, when sort of the antibody hits the antiserum, it will form a precipitate, or the other way around. It'll form a precipitate and form a band if there's a monoclonal. And so here you can see that in IgG, we've got some staining here, but there's no specific band. And it's quite normal for all of us to have sort of what we call polyclonal or non-specific immunoglobulins in response to inflammation. Then in IgA, here you can see that there's this smearing, but in the middle of the smearing, there's a very dense, well-delineated band. And this is sort of in the same, if we had to orientate ourselves here, sorry, I didn't orientate everybody, but this is albumin here, this is alpha 1, alpha 2, and our beta region. Beta isn't that well delineated on gel electrophoresis, so you can't always tell beta 1 and beta 2, but this is sort of our beta 2 area here, and this is where this band is. And so here we can say in our beta 2 region, we have an IgA monoclonal. There's nothing in IgM, and then in kappa, once again, you can see this well delineated band over here. And so this little peak here in beta 2 types as an IgA kappa. This over here is a patient with a raised beta 1. This is the main reason I want to show it to you. I don't have an immunofixation for this patient, but the important thing to note here is that beta 1 can be raised because of iron deficiency or an IgA monoclonal that can migrate here as well. And then I just wanted to touch on things that can cause interference. I did say antibiotics, but I think specifically the penicillins and contrast media. And then this patient also has a small irregularity here on the right-hand side of the curve. And I mentioned earlier that these can often be increased in inflammation, and it's not impossible that there's a small monoclonal here, but most commonly viral infections or inflammation that sort of causes sort of slightly specific immune response, forming this small irregularity that will disappear once the patient gets treated normally. And then this is just a hypogammaglobulinemia, so a low gamma region. And yeah, so essentially in the public sector, in the NHLS, these are some general costs of a full protein electrophoresis. So whenever you order a protein electrophoresis, we'll measure a total protein, which costs around 50 Rand. Then the actual serum protein electrophoresis costs about 120 Rand. And then if we add on immunofixation, it costs 430 Rand. So we don't routinely do immunofixations for all patients, just because they are 4 times the cost of just a plain serum protein electrophoresis. And so you'll often see we add on a comment If there's sort of a slightly, I guess the word is iffy history, we'll put in a comment saying, just give us a call, contact us on our number if you would like immunofixation added based on the clinical history. But we don't always routinely add this. I'm sorry that I've rushed through this talk. If you want me to go back to any slides and discuss anything in a little bit more detail, you're welcome to ask me to. I've just tried to rush because we are running out of time. These are my references, the teacher textbook of clinical chemistry. And in this book here, if anyone wants to go and read up about electrophoresis, this book, Multiple Myeloma and Related Serum Protein Disorders, an electrophoretic guide by N. Harris, is an excellent book that I can highly recommend.
Cameron, thank you so much. That was wonderful. Great overview again. Really, really appreciate it. And I have not seen, from my side, I can't see if there are any questions in the question and answer box. We are going to abbreviate the meeting a little bit. We're going to ask Caroline Rich, Estella's already spoken to her, to give her talk at another occasion. So that's something to look forward to, but our apologies to Caroline for the technical glitches. Just for interest's sake, I noticed that there seems to be a problem with Zoom because one of the meetings hosted from a colleague in America, he sent a note just now to say they're having problems with Zoom. So maybe it's not just here and that he had to create a new link. So the chat is also working. I can see already some people in the chat. You can just add in any questions or comments there. But while you're busy doing so, I just want to say once again, big congratulations to Igazi, to all the people involved with the BMS Foundation, to Alejandro that's joined us here in Cape Town. It's wonderful to see that myeloma is getting more of the attention that it deserves. I'm hesitant to say that it's getting all the attention it deserves, but I think the time has come for earlier diagnosis, better treatment. These patients can really do well, and we need to get to the place where our patients can also have a median survival of 10 years, as is now the case for many people in the rest of the world. So we will continue to fight for access to cheaper drugs, get more hematologists out there in the field, and also make our general practitioners and our nurses aware of the diagnosis so that patients can be referred earlier if they have those indications. I see there's some comments. Thank you, Cameron, for a brilliant talk. And I don't see any specific questions at the moment. I did think that it was an interesting thing to show how iron deficiency, and knowing my own biases, how that also affects the protein electrophoresis. When Cameron first gave this talk, I thought that was really, really excellent. And I think it's, although, you know, we must remember that in medicine, many things are classified artificially. And I want to encourage the trainees to not limit yourselves to, I'm now studying to become a hematologist, so I'm just reading hematology. The world is much bigger than that, and we want to be good doctors that know a lot about many other things too. And the fields that are close to us, we must really explore that, like chemical pathology where relevant and many other areas. It just makes our lives so much more rich. Thank you, Farah, who says, Farah Rahman, that was an excellent breakdown on electrophoresis. We need talks like this to reach more people in the general wards of surgery and medicine. I totally agree. And I'm sure Cameron wouldn't mind if you contacted him if you don't have somebody in your area to speak. I really agree with that too. It is 17:37, so I think maybe we should close here. We will engage with our IT teams to find out for the next week, before next week's session, what the challenges were, and try to make sure as best as we can that it doesn't happen again. There are unfortunately things outside of our control, but as far as it is inside of our control, we will definitely do that. There's one last question. Gideon Ruder. Cameron, he asks, beta gamma bridging as in cirrhosis much different from the IgA clone. So I suspect that means is the appearance on the protein electrophoresis very much different with beta gamma bridging compared to an IgA monoclonal protein?
Yeah, so it does look quite a lot different. I'm just going to bring up my slides again quickly, and just so I can point to.
That's a great question, by the way, Gideon. I think really relevant. Thank you.
So in this picture over here, can everyone see my?
Yes, we can see it. Thanks.
Perfect. So essentially, with beta gamma bridging, what will happen is that this beta peak here will essentially merge into the gamma region and almost become flat. We also generally have other biochemistry available to us that would sort of allude to liver failure, which sort of tips us off towards beta gamma bridging caused by cirrhosis. So this one here was an IgA clone, and here you can see that sort of we've got our beta to sort of peak over here, and it comes down a little bit, and then it goes back up before coming back down into the gamma region. And that's fairly typical. Oftentimes these will be slightly larger, but the difference on the SPE really is that the beta gamma bridging, I think that the IgA is more sort of, we use the sort of term polyclonal fairly loosely, but essentially the reason why our immunoglobulins sort of create this larger sort of curve like this is that they're so varied in their morphology and their sizes and their charges. So each immunoglobulin essentially functions like a different protein. If you think about it, it binds to different antigen site, antigen binding site, and so on. And so all of them are slightly different. And so you can imagine that in each little section over here, there's different immunoglobulins that migrate to each little different section. And so in cirrhosis, you're going to have a polyclonal IgA. And so you're going to have this more sort of broadened sort of diffuse increase in IgA. Whereas when you've got one plasma cell that's proliferating and producing one immunoglobulin clone, all of those immunoglobulins are going to have the exact same migration characteristics or the exact same electrophoretic mobility. And so they're all going to migrate to the exact same spot and look, sort of have more of this kind of appearance. This is a bit drastic, but it's because they're all migrating to the same place, they're going to have this more well-delineated sort of feature on the SPE graph. I don't know if that answers your question.
Yep, it sounds like Gideon is happy there.
So just one extra point here is that we're starting to standardize the way that we report on SPEs, and we're moving away from reporting on beta gamma bridging. And the reason for that is that the SPE's main use is to pick up monoclonal proteins or monoclonal gammopathies. And cirrhosis and liver failure have much better tests for their detection. And so by adding sort of all of this bloat to our comments, we're finding that we're creating a lot of confusion to less experienced clinicians with no real sort of benefit really when a liver function is cheap and sort of, the clinical signs of liver failure are generally fairly well taught and so on. And so we're moving away from commenting on beta gamma bridging, but you'll find that many labs still do report them. But that's the reason why I didn't bring it up in this talk. And I see another question here. Okay, so the question is that SPE doesn't pick up all cases of myeloma. So I think it picks up, the literature sort of speaks sort of between 90 and 97% of myelomas will be picked up on SPE. And then I think that's with an immunofixation though. And then that goes up to about 99% if you include a serum free light chain ratio together with it. Light chains don't always get picked up on an SPE. I think that's absolutely true. we don't run the free light chains in our laboratory. So I don't often get to compare when an SPE sort of doesn't show anything and the light chains do return a sort of a remarkably skewed ratio towards kappa or lambda. I also have seen very small light chain, sort of monoclonal light chain peaks on an SPE. So it seems variable depending on, I guess, the electrophoretic properties of that specific light chain. Sometimes we can detect them fairly easily, and sometimes we can't. And I don't know when or why that happens. Okay, so there's a follow-up saying that recently had a light chain myeloma with free lambda pickup on SPE, but the free light chains was normal. Wondering if something went wrong with this free light chain test, if a sample was swapped or some pre-analytical problem. And it's a great point, and neither of these tests are perfect. That's the first thing. And so in inflammation, so if this patient had a lambda light chain, maybe it wasn't very big and they had some inflammation, and so they had a large amount of polyclonal kappa being produced, which created this normal ratio. We know that patients with myeloma have got a lot of co-inflammatory conditions sort of that could come together with their myeloma, whether it be a presentation with infection or whatever it might be. And so that can sort of create a fictitiously normal serum free light chain ratio. In addition to that, we've seen numerous cases where we found for example, a kappa light chain on our immunofixation, but the serum free light chain ratio is skewed towards lambda. And we've sort of reviewed a couple of these and double-checked results and ensured that we sort of don't have a patient sample swap or there's some analytical error. But it seems that on follow-up of these patients, that persists, and we don't have an answer why. And it's something that we're currently auditing, but don't have an answer for that as yet.
With that, I think it is time to close. Cameron, once again, thank you so much for this great effort and all the visuals. That's always wonderful to see. And I wish you all a fantastic week, and we'll see each other hopefully back here next week, Monday. Have a lovely evening. Thank you, and bye-bye.
Bye.